and surgeon for St. Agnes Hospital. He completed his residencies at Iran University of Medical Sciences and the University of Illinois at Chicago/MGH. So as with many of our foreign-born doctors, he did a full residency in Iran in general surgery, and it was so much fun. He came here and did a second one. So he's like triply brilliant. He also completed a fellowship at the Medical College of Wisconsin in vascular and interventional radiology. He is board certified in general surgery. He is board certified in vascular surgery. He speaks Farsi, Turkish, and English. I present to you the good Dr. Alizadeh.
Thanks for the nice introduction. All right. Finding a subject to present for this session was not very easy, but because I believe that most of you guys have more experience in seeing patients than me, but just wanted to go over some general rules and preferences in imaging studies in vascular surgery. And when we are seeing a vascular surgery patient or a patient with possible vascular problem, the type of imaging that we want to order or request depends on what kind of question we are going to answer. The first question I think should be if there is a vascular problem or not. For example, a patient comes to your office with claudication or pain in lower extremity. You want to know if there is vascular problem, or is it a back problem, neurologic compression, or anything related to muscle spasm. So I think ordering a physiologic test will be your first bet or first test that you want to do. And if there is a vascular problem, what level, what location we are talking about. But let's stop there. Before jumping into imaging, I wanted to emphasize the importance of physical examination, because it's easier for us to order a vascular test before exactly find out what is going on with the physical examination, in terms of knowing the chief complaint, pain, or other symptoms like swelling, wounds, or if we are seeing a patient that had imaging before and we are looking into a diagnosis by seeing changes in the imaging. And sometimes we see patients where a vascular patient had a graft or aneurysm, and we do imaging, and we are doing surveillance on their aneurysm, and there's a recent changes. Also, sometimes they come with weakness or neurosensory complaints, coldness, warmth, numbness, and hypersensitivity, or discoloration or swelling. Tissue loss and ulceration. Tissue loss and ulceration means patient is having critical ischemia, and this is an emergent issue. We have to take care of it as soon as we can. Also, initial onset of symptoms, if they are acute or chronic, or they have symptoms on both sides, or it is or if it's unilateral or proximal or distal, and also quality of the symptoms, and if there's any factor that will mitigate or relieve the symptoms. Also, physical exam, we need to check pulses. Always look for pulses. If you can't find it, then you can look with Doppler. And probably it's a misnomer or something that we are not doing correctly. On the floor, especially with nurses, not here, everywhere. They call, well, I had. They said, when I asked them, well, did you feel the pulse? They said, no, I didn't feel it, but I had pulses with Doppler. you know, the sound that you hear with Doppler is not a pulse, it's a signal. Pulse is something that is palpable. So we should not call it a pulse. And then we look at the wounds. If there's good caprifill is a caprifill that is less than 2 seconds. And if it's delayed, it means that you have a vascular problem or perfusion problem. Swelling and edema could be a sign of reperfusion of the limb or a venous issue or venous return issue or reflux. Also, loss of motor and sensory function is one of the problems that vascular patients may have, and it's due to lack of perfusion to the nerves. Also, cellulitis and inflammation. So vascular patients are more prone to get cellulitis and inflammation because the lack of perfusion will put them more prone to infection. So I have only a few cases here to just review and see what you think, what are your thoughts about ordering tests, or what you think we should do with these. Simply, a 69-year-old woman presents to your office with history of AFib on warfarin with chief complaint of acute onset right lower extremity pain. What do you think we should do? Physical examination is the first first thing you want to do. Yeah, so it's so in physical examination you will ask about the duration of the pain, location of the pain, and if she had pain before, but it looks like this is acute. And if you know, probably you know that when you have ischemia of lower extremity or upper extremity, the golden time is 6 hours, and you want to resolve the issue or reperfuse before 6 hours, because after 6 hours you will get contractures, you will get a necrosis of the muscle and other tissues. So all teaching for these patients like her was that, well, you just take her to the operating room, because this is acute and you want to resolve it as soon as you can. But if you still have time and you think you can get a CT angiogram, that's a reasonable thing to do, because there are other causes that may other causes to other reasons for having acute onset right lower extremity pain and ischemia of the right lower extremity. For example, patients who have popliteal artery aneurysm may embolize from popliteal artery, and then if you take this patient to the operating room without having imaging, then you are in big trouble, because treatment for popliteal artery aneurysm is very different, because you can't just do embolectomy and remove the clot. The whole cavity of the popliteal artery aneurysm is full of clot, and you will embolize it distally. So if you have time, it's reasonable to do a CT angiogram for this patient. And of course, after doing a full physical exam. This patient comes with buttock and bilateral thigh pain. And let's say that this is going on for 6 months. What do you want to do? Again, physical exam. Yes, we did the physical exam, and he has diminished pulses in both femorals. Now, what we do is, it's better to go with the non-invasive testing. The most non-invasive test is doing either ABIs or physiologic tests. And then we can move forward. If let's say that ABI will give you some information, diminished ABIs and low pressures, then you can move forward and do CT angiogram, and then if it's needed, you can do more invasive testing like angiogram and intervention. This one comes, a 42-year-old woman presents with non-healing wounds above the right ankle. What do you think it is? What do you want to know about this? Anyone?
She a diabetic?
I'm sorry?
Is she a diabetic?
She is not, no.
Sickle cell? Sickle cell?
Sickle cell? It is possible, yes. What is so? Let's say that when you get more history, she tells you that, well, when I walk, it starts hurting, but I can't continue walking without severe pain. And also, she has severe swelling and edema on both lower extremities. This location of the wound will give you some information, and you have some hyperpigmentation around it. Venous also. So after doing full physical exam, the first order you want to do is the ultrasound of the veins to see if there's reflux or not. And if you do, let's say, if you do a CT angiogram for this patient, it's not going to give you any information because arteries are going to look normal, and you will, since you didn't do any physiologic test or dynamic test, you will not get any information, and you will not get the answer to your questions. So the techniques that are used in vascular surgery, either they are physiological studies or ultrasound, as CAT scan, MRI, and angiogram. We'll go over all of these the studies that are used and briefly explain what they are. Physiologic studies, they add a degree of objectivity to your physical exam, meaning that you have an evidence that there is a vascular problem, but they may not give you the level of the problem, if they are proximal or distal. And also, they will bring into question the clinical impression or detect disease in asymptomatic patients, or they will estimate severity and location for planning intervention. For example, sometimes if a patient comes with coldness of lower extremities or redness of lower extremities, if you do a physiologic test and do ABI, and your ABI is normal, then you will shift toward Raynaud's phenomenon or other non-vascular diseases. Also, if you do ABI for a patient who is not complaining of severe pain, but if it's 0.7 instead of 1.1, you will know that there is some vascular disease going on, and but it's not at the level that you need to do intervention, but you need to monitor that. And sometimes we do these physiologic tests like ABIs or plethysmograms to detect graft stenosis. A patient who has a graft or bypass, and they are, we usually monitor them with ABIs and velocities. If the velocity increases before they notice any change in the perfusion, we can do intervention and do stenting or ballooning of the stenotic area or narrowed area. Duplex ultrasound is based on the detection of the return wave from the transducer. So transducer sends the ultrasound wave, and this is RBC that is returning that wave back to the transducer and detector based on the velocity of the movement of this RBC. If it's going toward the transducer or moving away from it, the frequency of the return wave will change, and you will see it as changes in color. So this is a carotid duplex ultrasound, and you will, if you look at the duplex ultrasound image, you will always see this, which is a color bar, and it will tell you so it will tell you that anything that is moving toward the transducer will be red, and anything that is moving away from it is blue. So this is right at the bifurcation of the carotid. This is external carotid and this is internal carotid, and your transducer is here, right? So this flow is moving toward the transducer, that's why it's red. This is moving away from it. And this is an interesting case because you see that how wide it is. This is out of our discussion, but this looks like a carotid body tumor. This is too wide for internal and external carotid angle. And again, here, your transducer is always at the level of the skin. Moving toward it is red, away, I'm sorry. So this is backward, you see that? So first thing you do is look at this. Blue is toward and red is away. So this is the indicator. You look at it. Anything is on the top is toward and away is below. So this is moving away and moving toward, moving away. And this graph shows the level of decrease in area and the flow related to the level of stenosis. So as you see, when you decrease in diameter of the vessel by compression or narrowing, the flow will not change until you reach less than 70%. That's where it's critical and the flow starts to drop. So any stenosis below than 70% is not critical in terms of flow. Velocity may go up, but the velocity goes up to compensate, but the flow does not change, and then flow drops significantly after that. This is one of the ways, or one of the scales that we use for carotid artery duplex. Any peak systolic velocity less than 125 is considered normal. And less than 50% is again less peak systolic velocity less than 125, and the same criteria. So when you look at the report of the carotid artery duplex, clinically it's not important if the stenosis is if the stenosis is less than 50% or around 50%. It gets more important when you have 50 to 69 or greater than 70%. So, but when peak systolic velocity is above 125, your stenosis is greater than 50%, but it's still less than 230. And then when you're narrowing or stenosis is more than 70%, the end-diastolic velocity gets increased, and your ratio of these two, ICA to CCA, or internal carotid to common carotid velocity, becomes more than 4. This is where we are involved, and we treat this carotid, because this velocity and this narrowing is critical. And if it becomes near total occlusion, means that 99%, and all of any of these velocities could be variable. In total occlusion, well, of course, they are not detectable, and we don't treat those. If a carotid artery is down, and we don't do intervention, we don't recanalize them, because there's no benefit of doing that, and you will put them in risk of stroke. There are other applications for duplex ultrasound. Peripheral arteries, you can look at the arteries and locate the location of the plaque or stenosis. Has one of the important applications is mesenteric artery evaluation. Mesenteric artery stenosis is one of the clinical conditions that patient usually will come with food fear, and then they can't eat, and then they lose weight. So the first test will be mesenteric artery evaluation if you have high index of suspicion, and based on the velocity of the mesenteric artery, you will judge if there's narrowing or not, or stenosis or not. Renal duplex ultrasound is another one, which is very helpful as an initial test. Dialysis axis evaluation, sometimes patients who have a fistulas or they have graft, the stenosis of the graft of the anastomosis will be detected in the duplex ultrasound. Also in evaluation of the impotence in men, PBI index or penile brachial index, which should be greater than 0.5 or 0.6 is another test that is used. In arterial waveforms, we have 3 types of waveforms in our physiological studies. Usually the waveform should be, normally it should be triphasic, upstroke, downstroke, and another late upstroke. This third upstroke is due to elasticity and recoil of the artery in diastole, which kind of pushes the blood to downstream. But that quality will be lost in more calcified arteries, and in severe stenosis and severely calcified arteries, you will see a monophasic waveform that does not have any other downstream or upstream. It's just monophasic, and you just hear the voice in your duplex like a very constant wave that goes up and comes back to the baseline. How the ABI Rankel brachial index is done. You put the cuffs around both arms or measure the blood pressure on the brachial artery, and then you should check it on dorsalis pedis and posterior tibialis, and then you divide the pressure to the highest brachial. And the normal is always greater than 1 to 1.29. If this number is greater than 1.3, that is not, that's abnormal and is due to non-compressible vessels. And 0.9 and 0.9 to 0.99 is borderline, and anything below that 0.9 is abnormal, and severe peripheral arterial disease is when it's below 0.4. Usually that's when the tissue loss starts and there's no enough perfusion to periphery. This is showing how it's done, and you can so it should be done on dorsalis pedis and posterior tibialis. And as the severity and extent of peripheral artery disease increases, the ankle brachial index will decrease. Any ABI, so ABI tends to be greater than 0.5 with single vessels. So if you have any ABI less than 0.5, it means that you have disease more than one level, probably iliac, femoral, and popliteal, say in 3 levels. Most of the patients with intermittent claudication have ABI between 0.5 and 0.9. Claudication has its own definition. It means that, clinically, patient comes with complaining of leg pain, thigh pain, or buttock pain. Sometimes you can have claudication in other places too, in arm, in jaw claudication, for example, in temporal arthritis. So it will happen with the same level of activity. It's always at the same level, and you can create it with the same level of activity every time, and you need to, or patient needs to rest the same amount of time every time. For example, they say, they come and tell me that, well, I can just walk about 50 feet, and I have to rest for 5 minutes, and I can walk again for another 50 feet, and it happens every time. Interesting thing about claudication patients is that the risk of tissue loss for claudication patients is about 5 to 10% in 2 years, meaning that they don't have high risk of tissue loss. That's why the first intervention for these patients is quitting smoking and walking program to let their body form more collaterals. And patients who have breast pain, usually the ABI is less than 0.4, and it means that they are in critical ischemia, and those who are getting gangrene, the ABIs are below 0.3. So this is about the peak systolic pressure. So you know that, so the ABI is greater than 1. And it's interesting because usually the further you go away from heart, the pressure should drop, right? Your pressure in your toes, peak systolic pressure in your toes are greater than what you have in your, not in your toes, in your DP or PT are greater than brachial. Why does that happen? If you look at this, so the pressure in brachial, let's say if it's 130, but pressure in DP or PT in the same person in 160. That is correct, it's higher, but the difference is that mean pressure decreases as the pressure wave travels distally. Although mean pressure decreases as the pressure wave travels distally, peak systolic pressure increases. As a result, ankle systolic pressure is normally about 10% higher than brachial pressure. Why? Because peak systolic pressure is accentuated by the additive effect of reflected pressure waves from the periphery. But the mean pressure will drop. Also, another importance of ABI is that it has predictive value. Measurements more than 0.5 are infrequently associated with progression to critical ischemia over the next 6 years. These are different studies that are been shown that abnormal ABIs have been associated with increased overall mortality. And also, it's a very useful office screening for asymptomatic patients older than 65, and also American Diabetic Association has recommended similar screening with ABI for diabetic patients older than 50 year of age. So these are the toe pressures. Toe pressures are part of the physiologic test. They put cuffs around the toes and measure the pressure around the toe, and it's just the pressure, it's not an index. These are non-diabetic and non-diabetic and diabetic patients, and asymptomatic patients, anything ranging from 50 to 150 to 180. The normal toe pressure for us is around here, 70 is normal. So toe pressure of 70 is normal. And then patients with claudication, usually the toe pressure is around 50 or less, and patients with rest pain, their toe pressure is around 30 or less than that. Usually toe pressures are less in diabetic patients, but toe pressures are very good. Toe pressure measurement is a very good tool in measuring perfusion in diabetic patients because they are not significantly different from the normal population. If you look at ABIs, ABIs are usually in advanced diabetic patients, ABIs are not measurable because their medium-sized vessels are not compressible, but toe pressures are still measurable. This is a venous study that I'm going to skip. Plethysmogram is another way of measuring the perfusion. It's based on, clinically, I haven't seen this to be done in clinics or in practice, but it is based on the changes in volume of the extremity in that period of time. So because the volume of the other structures, bone, muscle, and tendons, they remain the same. The only thing that changes with every heartbeat is the volume of the blood that is pumped into the extremity. So the changes in the overall volume, which will be equal to the volume of perfusion. Now, another imaging study that we use very frequently, sometimes I think we are overusing CAT scans, is, this imaging, which is a CAT scan. It was invented in 1930s by a Dutch radiologist, and it was very tedious and time-consuming. The first generation was very time-consuming study, but it was a great leap forward in imaging advances. So the combination of hardware, mathematical algorithm, and the computer software will give you the images that we have now. The first scanner was installed in England, in Wimbledon, England, 1971, and first installation in the U.S. was done in Mayo Clinic in Rochester, Minnesota, I think in 1976, probably. I don't remember the exact date. First generation CAT scan used to acquire two adjacent brain tomographic sections in about 4 minutes, and it is 7 minutes for computation. So every slice used to take 11 minutes. But now you can do the whole body scan in less than 30 seconds. This is how the first generation CAT scan used to be, and you have this emitter and detector on the other side, and the patient is in the middle. So they used to take pictures and scan every time and move, and they used to do it perpendicular to that axis. And then you had the second generation, which was rotational CAT scan that they had 360-degree rotational emitter and then detector on the other side. Now we have the spiral CTs that are third generation, and they're really quick, and the software has been. Now we have a very advanced technology in software and reconstruction of the images, that you can look at the image in any direction, or you can do 3D reconstruction. The difference between CT angiogram and the regular CT with contrast is mainly the way it's processed and the volume of the contrast that is given to the patient. So in CT angiogram, we are looking for arteries basically we are looking for the structures in arteries and in narrowing, stenosis, or blockage. So it's so the bolus of the contrast is being given to the patient, and then the CAT scan follows the flow of the contrast in the arteries. That's why we see the arteries better. In regular CT scan with contrast, we give 120 to 180 ml of contrast, but with recent advances in technology in CTA, the contrast may not even exceed than 100 ml, which is safer for the patients. These are images. Mainly one of the main usages of the CAT scan is for aortic pathologies, aortic imaging. You can, this is a coronal image of the arteries, and you see that in reality, when you give contrast to a patient, it will not stay there. So this is processed, that's why you see the contrast in all arteries. The computer will chase the contrast and overstack the images so you can see all the arteries visualized. Here, for example, in aortic pathology, you see this is a dissection in the ascending aorta. You see the through lumen and false lumen. False lumen is usually darker, and through lumen is on the other side. This is type A because it's very proximal. Again, another sagittal view of the CT angiogram of the dissection. You see this is the false lumen, and this is the true lumen. Another CT angiogram. These images are 3D reconstruction. These are all processed by the computer, and it will help us to find out or see the spatial relation of the arteries or configuration of the arteries in CT angiogram. This is a 3D reconstruction of the carotid artery, and you can see that there is a lesion here and there is narrowing here. And in order to realize which one is internal carotid, because internal carotid is the one that we are mostly concerned about. We don't really care about external carotid as long as the other side is open. Internal carotid, when you look at the image, is the one that does not have any branches, and it's usually larger than the other side, larger than the external, larger than the external carotid. External carotid, first we'll start with the thyroid or superthyroid branch, and then lots of pharyngeal branches, but internal carotid does not have any branches in the neck, and that's how I find it in the operating room, because sometimes one of them is in front. There's no, they are not constantly front or posterior, so I have to look to see if there's branch, so that one is the external carotid, the other one is internal. What do you think it is? Aortic pathology. You see, it's an aorta. This is very ugly. Yes, it's an aortic rupture or impending rupture. So when you look at the CAT scan, so if you see this, you should page me, please. So when you see the lumen of the contrast, it is contained, but had leaked into the fatty tissue. When you see leak of contrast into the fatty tissue, you see that this side should be almost comparable to this side in terms of CT number or darkness, but you see that this is very different, and if we don't fix this patient will die. Clinical applications, as I mentioned, aortic disease, peripheral vascular occlusive disease, venovascular disease, venous disease. So difference in venous disease with CTA is that we will do CTV or CT venogram, and it means that we will wait, or the computer will wait until the contrast reaches the venous system and then start getting the images. Also, vascular malformations like congenital malformation, AV fistulas, CT angiogram could be a very helpful tool. CTA is the primary imaging modality for aortic disease, especially for preoperative planning of endovascular repair, also for postoperative follow-up. Now, most clinicians or vascular surgeons are trying to stay away from CTA for follow-up after the aortic repair, because there are good studies showing that ultrasound is a safe method to do that, and we will switch to ultrasound, I think, soon for follow-up of these patients. And now, comparing to MRA, we order MRA, we do MRAs here too, and for carotid disease, for many of aortic or peripheral vascular disease, but there's an important advantage of CTA over MRA. With CTA, you will see the calcium, but MRA is not a good tool to evaluate the calcification, especially around the neck of the aorta. So CTA is preferred over MRA for aortic pathology. Also, CTA is preferred for carotid artery disease over MRA, because MRA tends to overestimate the degree of stenosis. CTA does that too, but to a lesser extent. Also, when you put endovascular devices in the vessel, CTA is preferred because you have metallic scaffolding or metallic prongs in the aortic endograft, and in MRA you will have lots of metallic artifacts. Well, this is a reconstructed image of the aorta for evaluation of the neck. Neck is the distance between the lowest renal and where the aneurysm starts, seal zone or neck. So for us, the minimum length used to be 1.5. Now we can do less than 1 centimeter. We can repair aneurysm with less than 1 centimeter of sealing zone, and it's successful. This shows how the endograft goes up in the aorta, and we just landed just below the lowest renal. There are metallic parts on the proximal part of the endograft, and they are called aortic fixations. They are very sharp, and then they just are prongs that get into the aortic wall and keep it in place. Also, this CTA could be used to image arterial tree from the aorta through the pedal pulses, through the pedal vessels. It is highly accurate in imaging tibial artery runoff. On this, you have severe calcification in distal arteries, which is a drawback for the CTA. So if you have very calcified arteries, like which patients, like diabetics, like patients who are on dialysis, it is not the preferred method of studying those vessels, and I prefer just to, personally, I just do catheter angiogram, because that's the best way to see the arteries. And sometimes you can do MRIs. MRIs are better in very distal vessels if you have calcification, because they will not show the calcification, but they will show the lumen of the vessel. In terms of renovascular disease, if you are concerned about renal artery stenosis, CTA and MRA are comparable, and there's no advantage on any of this. But MRA suffers significantly from respiratory movements of the kidney, but by doing MRI, contrast-induced renal nephropathy is avoided, and the limiting factor is interstitial fibrosis due to gadolinium in patients with severe renal failure, or patients who have very low renal function. Also, CTA is very good to detect mesenteric venous thrombosis. Also, it has replaced lung perfusion and ventilation study. Do we still do lung perfusions here, or we just do the CTA?
No.
We do for patients who can't get contrast. Okay. And also for peripheral venous disease, if you do CTV. CTA is good for vascular to detect vascular malformation only if they are high flow, because the low flow, you can't see any low flow malformation unless you do a CT, unless you do a catheter angiogram or venogram. And For these malformations, for low velocity malformations, ultrasound and MRI are the modalities of choice. What are the risks for it? The radiation dose. So we know that we radiate the patient every time we do a CAT scan. And in the past, physicians who were ordering CAT scans were not aware of long-term carcinogenic potential, especially in pediatric groups. It was estimated that between 1991 and 96.4% of all cancers in the United States were attributable to CT studies, but now this number has increased to 1.5% to 2% of all cancers. And I think most of it is because of the surveillances that we do, and we are trying to find a way to stay away from it. Contrast-induced nephropathy is the third most common cause of iatrogenic acute renal failure. How could it be prevented? Of course, you can. If you could find another imaging modality without contrast, that's a good option. Or if you have to do it, it's better to hydrate the patient before, during, and after the CAT scan. Bicarbonate drip or other medications, even though we practice in clinical, our clinical practice, but they are not as effective as hydration with normal saline. If the patient can tolerate it. So when we compare, basically we compared, if you compare CT versus duplex ultrasound and MR, well, they have their own applications, but duplex ultrasound is non-invasive. It's one thing is about it is operator dependent. So it's impossible to get the same number or same reading for example, a carotid ultrasound. If two experienced takes two carotid ultrasound for carotid stenosis, one of them may give you 350 centimeter per second, the other may give you 280. It is very operator dependent, but if there's then stenosis, it will show it to you. And also, because of that shadow effect that you get from the heavily calcified arteries, it has limited value, duplex ultrasound. So whenever there's a calcium in the surface, and the ultrasound wave will not be able to penetrate through it. So you will see shadow under it, and you can't see anything beyond that. So when you have heavy calcification, it's not a good tool to evaluate in terms of the diameter or sizing the artery, but you can see, you can evaluate the velocities. And of course, it's very challenging in these patients. CTA is excellent modality for the evaluation of the aorta, and also in calcification, large calcification in access arteries. Access arteries means femoral arteries mostly, or brachial artery for the access in the interventions. In landing zone for the EVAR, and it's not preferred in calcified distal arteries, because everything will look the same. Calcium and contrast will mix up. MRA is less useful in large calcified arteries. You can't do it in end-stage renal disease because you may get nephrocalcinosis, the severe reaction to the gadolinium. But it is preferred in calcified distal arteries. Now, despite the advances in non-invasive imaging of CTA, MRI, and duplex imaging, the catheter angiogram is the gold standard, still the gold standard, because you see the real lumen of the artery. When you push the contrast into the artery, you have a real-time imaging of the artery, and you can always compare other imaging modalities with the catheter angiogram. And it is getting more common because many first-line treatments are endovascular now. For example, limb ischemias. we don't jump into surgery nowadays. If we try to push, and this push is getting more and more because endovascular treatments are getting more successful, and technology is very advanced and advancing very fast. Also, arteriography has returned to the forefront of further development of advancing imaging techniques, and has become an indispensable hands-on tool for vascular surgeons and interventional radiologists and cardiologists. In order to do a catheter angiogram, you need the operating room or imaging suite or hybrid room. You can do it with a fixed mount or portable equipment, which is mostly used in the operating room. You will need catheters, contrast agents, which is either iodonated or CO2. CO2 is used for patients who have high creatinine level, and actually it's a very good tool for angiogram, but it's less commonly used. You can do power injection for the contrast or manual injection. This is the portable device, fluoroscopy machine that we use in the operating room. This is a fixed mount machine. And hybrid room, nowadays most of the institutions have hybrid room, meaning that it's a suite that you have this angiogram suite and also operating table. You can operate and do the angiogram at the same time. Catheters, we use flush catheters. They come in different shapes. We start with these catheters usually, and you will get access to the vessel with a sheath, and this catheter goes through it, and wire goes through the catheter, and we can guide the catheter and wire by just manipulating and turning to the different directions. These are examples of conventional and subtraction and CO2 angiograms. So I think, yes, these two are the same vessel. This is superficial femoral artery. You can see the kneecap, and this is profunda femoris. This is conventional angiogram showing a plaque here, showing narrowing here and here. And they have done the the CO2 angiogram by injecting the gas, injecting CO2 gas into the artery, and it will show the same areas of narrowing, which is a very good tool in patients with renal failure. This is another CO2 angiogram. It's femoral bifurcation, SFA, and this is another CO2 angiogram for tibial vessels, which shows narrowing here. This is usually we fill this bag with CO2 and aspirate the CO2 and inject it through the catheter. This is the subtraction technology. See, I mean, if you compare these two images, they are the same angiogram, but the software processes this. There's some motion artifact, there is some overlapping, but the post-processing will give you this image, which it shows so nicely that the arteries are patent. You can see the geniculate arteries, anterior tibialis on all the three vessel runoffs. So what it does is that it removes the motion artifact, and also it removes all the unnecessary parts of the or tissues like bones, muscles. The only thing you see is the flow of the contrast through the vessels. And also it has the stacking technology, meaning that when you inject, this is the tip of the catheter, you inject the contrast, and the contrast will be flushed away. It doesn't stay there. So this is the first picture, this is the second one, third one, you just see the contrast in the distal. But by stacking all of them on top of each other, you will see the image of the whole artery. Road mapping is another technology. So you do the angiogram, the machine will add this angiogram picture to the bony structures, And when you want to do intervention, that road mapping will stay on the image, so you know, comparing to the bony structures, where do you want to do the intervention. This is ballooning of the common femoral artery. Limitations, sources of error and superimposed vessels. Sometimes, for example, in this picture, you see that, well, it doesn't look like very stenotic, but when you rotate, you find out that this part was superimposing the other end of the artery, and you were not seeing it. You were seeing it as non-stenotic artery. Sometimes you may see when you put, you know that we use wires in order to put the endograft. This is an aorta with the endograft in. This is the same aorta that is repaired with aneurysm and wires inside the iliac arteries. You see that there's tortuosity in the arteries. But when we put the wires in, this tortuosity goes away and it becomes straight. You may see some pseudo-lesion. This is not stenosis. This is just because of the stiffness of this wire that bends the wire. After you remove the stiff wires, the angiogram will show that there's no stenosis there. And also multiplanar imaging will help to detect more stenosis if there's any overlapping. Of course, there's risk of bleeding, infection, thrombosis, toxicity, nephrotoxicity, cardiac toxicity, and hematologic toxicity and metabolic acidosis, especially if the patient is taking metformin. So overall, new imaging techniques are an adjunct to a focused vascular exam, but will not replace it. Non-invasive and physiologic tests are a good option as initial evaluation after physical exam, especially in non-acute cases. And risks, costs, and benefits should always be considered when requesting an imaging study. And angiogram is rarely an initial test in vascular surgery. We do angiogram whenever we want to do intervention because it's invasive.